insist that in gastrointestinal system you need to start, talking about diagnostic studies, because it's a very important topic in gastrointestinal system. So remember that the most basic is the occult blood or fecal occult blood. Remember that the name of the substance that is used to demonstrate the presence of hemoglobin occult or hidden in the feces is guaiac. So they can use the term guaiac as equivalent of fecal occult blood test. Remember that you should educate the client with a diet 3 days before the test to avoid any kind of food that contains blood, specifically red meat, and trying to open your mind to know that meatballs are made with red meat, that maybe sausages, etc. Nevertheless, chicken, fish, and pork are allowed. But there are some vegetables like broccoli and turnips and radishes that can produce false positive, so should be avoided. And if the client is taking medication that can produce gastritis and GI bleeding, which is not the real bleeding that is searched with this test. The real bleeding that is searched with this test is the bleeding of a polyp or a bleeding of a potential colon cancer. So when the client is taking NSAIDs or aspirin or corticoids that are medication that can produce bleeding in the stomach, should be withheld also 3 days before the test. The ascorbic acid, vitamin C, and also the fruits rich in vitamin C should be also withheld because can produce also false positive in the test. In my experience in Nclex, the most common questions is the teaching that you provide the client before doing this test. Remember that this is a very important test and is frequent in Nclex because the nurse practices this test. The client brings the specimen of feces, and the nurse applies the guaiac, and then if the color changes, the nurse reports to the physician. Remember that there are procedures to evaluate the GI system that are made with a contrast substance, radiological contrast substance called barium. Remember that the barium is not passing to the blood; it's staying in the lumen, in the cavity of the GI tube. Remember that GI system is upper GI, that is the esophagus, the stomach, and the duodenum, and the lower GI, that is the colon. For the upper GI, we have the upper GI series. Why is called upper GI? Obviously, because it's centered in the esophagus, stomach, and duodenum. Why is called series? Because several X-rays, a series of X-rays are done. Not only in the moment in which the barium is swallowed, but later, even 2 to 3 hours later, when the barium have advanced by natural peristalsis to the small intestine. That's why it's called upper GI series, because there are many X-rays. And a recent question that I was in Nclex is just exploring this detail, that a client is coming from an upper GI series and just had the GI series and the X-rays, and then returning to his room, his bed. What should ask the nurse before allowing the client to eat? And the answer was, if the client has pending a X-ray, a late X-ray to be done 2 to 3 hours later, because it is the situation the client cannot eat. Remember that for this procedure, the client is going to swallow barium. That's why it also can be called barium swallow. And for that reason, The client is not going to be sedated, is not going to have anesthesia in the throat. There is not problem to swallow. There is no need of gag reflex evaluation. And there is no limitation for transportation. So the client can drive, is an ambulatory procedure, etc., etc. After this procedure, the client is going to be pooing the barium, and for that reason, the feces are going to be whitish. Tell that the patient, so the patient doesn't, is not scared for this finding. And generally, some kinds of stool softeners or laxative are recommended to favor the elimination of the barium in the following days. Of course, a diet rich in fiber and abundant fluids. The other form of exam is the barium enema, in which the client is going to have previously cleansing of the intestine with cleansing enemas, and is going to have an enema of barium and X-rays. The same kind of precaution, the same kind of situation. The endoscopy, the upper gastrointestinal endoscopy to see the esophagus, stomach, and duodenum is the one that requires the sedation, and the local anesthesia in the throat is the one that the client cannot drive back home, and is the one that the clients cannot eat or drink until the gag reflex return. The position for the upper GI endoscopy is left lateral, recumbent and left lateral. There is a picture here so you can understand. The rationale of this is anatomic. If you observe the position of the stomach anatomically is this, so it's much more easier to go down to the stomach with the endoscope if the client is in this position. The position for the colonoscopy that also requires sedation, but doesn't need an anesthesia in the throat, obviously, yes? So there is no need of evaluation of the gag reflex in the colonoscopy. The client needs to be in left lateral, which is the Sims position. For after those procedures that are invasive, you need to observe the client for complications that are rare but possible, like bleeding, perforation, etc. And because we already mentioned upper GI endoscopy, bronchoscopy, that has nothing to do with the GI, has to do with the trachea and the bronchi, has the same requirements of the upper GI endoscopy. And when you study cardiovascular, remember there is an echocardiogram that is done through the esophagus, the transesophageal echocardiogram that has the same requirements of the upper GI endoscopy. The endoscopic retrograde cholangiopancreatography, a lot of names summarized in ERCP, is frequently tested in Nclex, is an endoscopy. But once the endoscope is in the duodenum, a catheter is introduced in the common biliary duct, and iodine is injected backward, retrograde, in the biliary tree and in the pancreatic duct. This is the ERCP. Of course, the requirements of an endoscopy, sedation, anesthesia in the throat, fasting, are added to the precautions in clients receiving iodine, like testing for iodine allergy. Remember that that these shellfish cross reaction with iodine has been discredited. It's not accepted anymore nowadays. I just was, looking for questions, practice questions in ATI. They still have this outdated information. So update this information because it's already updated in the Nclex. And if you don't understand this, make your own research. And I can tell you that your medical surgical book, the Ignatevicius, explains very clearly that there is no relation between shellfish and iodine allergy. You can find there the references and all the explanation there in your book. Remember that for iodine, renal function need to be evaluated before injecting iodine. Remember that if the client is diabetic and taking metformin, should discontinue the metformin 1 day before the test and don't reinitiate the metformin until 2 days after the test. This is what can be, in your interest. And because those are invasive procedure, always the client need to be monitored after the procedure for bleeding, perforation, and in the case of ERCP, because they inject retrograde iodine in the pancreatic duct, there is a possibility of, very remote, but it's a possibility of inflammation of the pancreas. I mean pancreatitis. Okay, pancreatitis. Those are the GI test. For paracentesis, remember that the paracentesis is done as a palliative, non-curative, palliative procedure, especially inclined with ascites and especially inclined with hepatic cirrhosis. And remember that this procedure is done because the pressure of the liquid in the diaphragm prevents the client from breathing. And a classical question, in which position is placed the client for the paracentesis and is as high as tolerated, high Fowler. Why? Because it's suffocating, is not breathing properly. Yeah, it's important to have the client void before the procedure to prevent having distended bladder that could produce an accidental puncture of the bladder. After the paracentesis, the client tends to have hypovolemia. So need to be left, okay, in high Fowler position, resting until stabilizing the hemodynamic. And remember that those are clients with cirrhosis, that the hypotension brought by the extraction of the liquid could precipitate an hepatic encephalopathy. It's common that after the paracentesis, some leak of liquid, persists. Is the only procedure in which leak after the procedure can be seen. In case that it happens, a compressive dressing should be applied and make the client rest lateral over the other side, the side where there is not puncture. If the leak doesn't stop, then report to the physician. Of course, also monitor for any sign of infection. For the liver biopsy, remember that is a very bleedy procedure that requires a perfect coagulation test before the procedure and contraindication if the client is taking any kind of medication that inhibit the coagulation, like antiplatelets and anticoagulants. So blood tests for coagulation need to be done before the procedure. The client is going to be resting comfortably in semi-Fowler or flat with the right arm behind the neck, while the doctor with local anesthesia in a very rapid movement, is less than 5 seconds, 10 seconds, is going to obtain the specimen, okay, with a needle that is introduced between the ribs. It's important to tell the client to hold the respiration in the moment, these 10 seconds that the physician is going to need to obtain the specimen. It's very important to hold the respiration. After the puncture, immediately after the puncture, once the dress is, the band-aid is placed there, the client should be turned to the right lateral position with the purpose of making pressure over the site of the puncture, and is going to stay in this position for several hours, 3 to 5 hours, with continuous monitorization of the vital signs. Of the pathology Pathologist of GI, please don't forget that in Nclex at least we are going to be tested about pediatrics. Okay, the cleft lip, mainly oriented in how we feed those kids with those bulky nipples. Okay, and how the surgery corrects the defects, and we need to care of the child after the procedure. Of the congenital malformations, also study esophageal atresia. Esophageal atresia is when the esophagus doesn't communicate with the stomach, so there is a cul-de-sac. There is a cul-de-sac here, the esophagus that doesn't continue with the stomach. So when the child, which is born normal, it's a normal child, is born and starts drinking milk, sucking milk for first time, you are going to see that the milk, instead of going to the stomach, cannot go to the stomach and is going to return through the nose. So the client started choking. Notice that here is the trachea. This is the trachea, and this is the cul-de-sac. So when the milk arrives here, returns through the nose, but also can produce choking of the child. The saliva cannot be swallowed, cannot go to the stomach, and frequently the child is generating a foamy saliva coming out. And of course, it requires surgery. So MPO and surgery. The pyloric stenosis is the other stuff that you need to study because it's frequent about GI in your test. And remember that it's a very thick and narrow muscle here in the pyloric valve, producing obstruction to the gastric emptying of the gastric content in the duodenum. The consequence is that the child that is born normal, when they start drinking milk, the milk has difficulty to pass from the stomach to the duodenum, and after a while, after filling the stomach with milk, the child is going to vomit the milk. Is going to vomit the milk in a very violent fashion, with what's called projectile vomit. Of course, the child is going to dehydrate and is going to be all time hungry, and doctors will examine the child, will notice the presence of this mass in the pyloric valve that can be palpated above and to the right of the umbilicus, like an olive-shaped mass, and with an ultrasound, which is the gold standard to diagnose that, they confirm the hypertrophy of the pyloric valve. Meanwhile, the child is vomiting, is at risk of dehydration, is at risk of aspiration, is at risk of electrolyte disbalances and alkalosis, metabolic alkalosis. Of course, it needs to be corrected ASAP, because otherwise the child is going to have failure to thrive because it's not receiving food. The surgery is very simple. It's a minimum invasive surgery that corrects the problem in a very efficient way. The Hirschsprung disease, which is the aganglionic megacolon, is the other name of Hirschsprung disease, is another congenital disease that produces distension of the colon, distended abdomen at the moment of birth, and constipation, and delay of the passage of meconium in the first 24 hours. When finally the child is having a bowel movement, the feces are going to be very thin and flat, and are classically described as ribbon-like stools. Those clients are at risk of developing an infection or inflammation in the colon called toxic megacolon. It's an enterocolitis that produces diarrhea, explosive diarrhea, very fetid with blood, and sepsis. So it is the complication of this disease. It is corrected surgically also. The intussusception, also in your Nclex, is seen generally in young children. The most common is the herniation or telescoping of the ilium This is the most common form. There can be intussusception any part of the GI, but in this case, the most common is the ileum in penetrating in the cecum. The child this occurs in an instant. In that instant, the child will start with a colic pain that is very intense. Is going to complain, is going to cry, it's going to scream, and is going to adopt a fetal position, flexing the knees against the abdomen. That is an antalgic position that alleviates the pain. Vomits can occur, and then the client starts expelling, through the rectum, a mucus with blood that classically is described like a jelly, a current jelly-like content, without feces. If the client, the pain disappears and then start having passage of a stool, brown stools, is because the intussusception spontaneously, reduced or corrected. Nevertheless, doctors can correct this displacement of the ileum inside the colon with an enema. So it's called hydrostatic enema reduction. So under fluoroscopic control, they introduce an enema that pushes back the intestine in position. There is a risk of a recurrence. The diagnosis can be done with CT scan, basically, of the abdomen. The celiac disease, remember what the child cannot eat: barley, rye, oat, and wheat. If you don't have good memory, you have this mnemonic brow: barley, rye, oat, and wheat. Of these 4 cereals that contains gluten, the protein that triggers the autoimmunity of the celiac disease that destroy the villi of the small intestine, producing diarrhea and malnutrition, malabsorption, steatorrhea, malabsorption, vitamin deficiencies, especially fat soluble. The treatment is the elimination of this protein. And this protein is only present in these 4 grains or cereals. The oats and the wheat are the most abundant. So the question that you're going to have basically is going to what not to have, what you can have instead. Remember that there is a lot of stuff that have a wheat, like bread, pasta, noodles, oatmeal, etc., etc. From appendicitis, always there is a lot of clinical scenarios. I think we have already practiced some of them in Nclex about appendicitis. Don't forget that the appendicitis is a disease that is manifested mainly by pain. Pain is the cardinal symptom of appendicitis. Pain that can start around the umbilicus, but then soon localizes in the right lower quadrant. It is true that the point that is characteristically exquisitely painful in appendicitis is called the McBurney point, and Nclex loves to ask about this name, but they are not going to demand you to localize exactly in the junction of the middle third with the distal third of an imaginary line between the umbilicus and the iliac anterior and superior iliac spine. This exact location is not going to be tested in Nclex. They are going to ask you in which quadrant. Remember that the abdomen can be divided in 4 quadrants. So the right and lower, and inferior quadrant is the place of the McBurney point. Remember that clients with appendicitis usually a part of the pain that is intense have anorexia, low-grade fever, tachycardia, elevated white blood cells count, and can have constipation or diarrhea, but the most common is constipation. The appendicitis is an urgency that should be resolved in the first 24 hours. So it's not ABC, it's not an emergency, but it's an urgency that should be resolved in the first 24 hours. Because It's a very simple, benign condition that can easily can be resolved by a minimum invasive surgery. But if the treatment is delayed, then can perforate, and now it's a complications, becomes a peritonitis that is a much more complex condition. That is not necessary. The appendicitis is confirmed generally by a CT scan. Remember, the patient that is under suspicion of appendicitis need to be NPO, needs to be prepared for surgery with IV liquids. Once the doctor ordered that, can be administered analgesics for the pain. The patient shouldn't receive any kind of laxative, local heat in the abdomen, any kind of enema, and should be placed in a comfortable semi-fowler position with a light turning to the right side to localize all the infected fluids in this area of the appendicitis. Localization is not important. Remember that for GERD, we need to recommend the client to avoid going horizontal after eating. I mean with the full stomach, because is when the reflux is going to occur. I prefer to study together the GERD with the dumping syndrome, because there are some stuff that are the same, interventions are the same, and other that are the opposite. So it helps me a lot to memorize. So the GERD, you know, is the return of the gastric content and the acid to the esophagus that is not prepared for this acid, and is going to produce inflammation of the esophagus and esophagitis, and an annoying symptom called heartburn. The chronic irritation of the esophagus can produce a pre-cancer, pre-malignant condition called Barrett's esophagus. So it's important. And the idea is when a person eats, to avoid feeling too much the stomach, because if the stomach is very distended, then it is going to produce gastroesophageal reflux. So it's better to have 4, 5, 6 small meals, okay, per day, instead of having 3 big meals. It is important to avoid drinking fluids with the meals, because it will, produce more distension of the stomach. But the client must drink fluids as any person, so can drink the fluids between the meals. And it's important to have the supper early, so when they go to bed at night, they don't have the stomach full. The bed should be elevated. The head of the bed should be elevated to use the gravity force to keep the fluids inside the stomach and without returning to the esophagus. Food that is produce a low secretion of acids, food low in caffeine, avoidance of alcohol, avoidance of tobacco, avoidance of NSAID, spicy food, greasy food, okay, the fried food that stimulate the secretion of acid should be avoided. And generally, the doctor prescribes medication to block the production of acid. The dumping syndrome is all the opposite. Dumping syndrome always is a consequence of a surgery. So remember that for dumping syndrome, you always have a history of a surgery in the stomach, either a gastrectomy or a reduction of the stomach for bypass, for obesity, etc., etc. So now we have a very smaller stomach without pylotic valve. And there is risk that when the client eats, to have the food without being dissolved by the stomach, passing dry to the small intestine, producing the symptoms of the dumping syndrome that are, pain, nausea, vomits, hypotension, and tachycardia, because this abnormality of passing dry food to the small intestine. And the interventions are in relation with the with the positioning is the opposite. We recommend the client to rest in bed, to be recumbent after eating, because it will keep the food here, and we allow the client to consume fat of fried food. But what we don't recommend the clients is to have sugary food, because the sugary food is going to produce a lot of osmotic activity here in the small intestine, producing exacerbation of the symptoms. The client should have the same recommendation as for GERD: small meals more frequent, avoid water or liquids with the meals, but is going to be recommended resting after eating. Okay, yes, those are the most important. For ulcers in the stomach, remember the risk factors: NSAID and Helicobacter pylori are the main culprits. Also, alcohol consumed is a risk factor. For the diagnosis of this bacteria, there is a test. This is called urea breath test, that is examining the breath, the content of this substance in the breath. Okay. Also, there are biopsies if they are endoscopy, etc. But this is the urea breath test to diagnose Helicobacter pylori. If the cause of the ulcer is Helicobacter pylori, the treatment must include antibiotics as part of the medication to block the acid. The gastric ulcers produce pain, abdominal pain, immediately the client eats, while the duodenal ulcers produce a pain that is delayed, is postponed 2 to 3 hours after eating. The gastric ulcers, okay, have a complication that cannot be seen in duodenal ulcer, and is the potential of transforming in cancer, stomach cancer. But either type of or location of ulcer can have 2 complications that you need to know very well. One is bleeding. While the ulcer is digging there in the wall of the stomach, they can find a blood vessel. The blood vessel can break, and if it is an artery, it is going to produce a massive bleeding. The blood that is spilled in the stomach quickly enters in contact with the acid of the stomach and changes color and consistency, form little clots of dark color that reminds the coffee grounds. So when the client vomits, probably is vomiting and emisses with this aspect of coffee ground. If you do an occult blood, a hemoccult test in this vomit, it will be positive in the confirmation. But if the blood passes through the pyloric valve to the intestine, it's going after several hours. And it is important to remember that melena, or the elimination of the blood in the feces, is going to take several hours of intestinal transit. The blood is going to be eliminated as melena, a tarry black stool, very stinky, and it is also a manifestation of upper GI. Only the upper GI, I mean duodenum, stomach, or esophagus, is the one that can produce melena. The importance of the hematemesis and the melena is not the aspect of the stuff, is how the blood pressure, how the hemodynamics, how the volemia behave. So you know that when there is an important loss of blood and also of volume, of volemia, you are going to have tachycardia and orthostatic hypotension, or overt shock, hypovolemic shock, sustained hypotension. So it's important that you give priority to the evaluation of the vital signs over any aspects of the feces or the vomit, etc., because the most important are the vital signs. The vital signs. If the client has an important volume of loss of blood or not. The other complication that the clients can present is the perforation. When the digging of the ulcer doesn't find a blood vessel, can continue digging until finally open a free communication between the interior of the stomach and the peritoneal cavity by the abdominal cavity. And you understand that now the acid and even the food that is inside the stomach, the cavity of the stomach, is going to be spilled through the opening, through the perforation in the abdominal cavity. It occurs in an instant. So the moment with the perforation finally, okay, the digging finally opens in the abdominal cavity, it's going to be in an instant. For that reason, the pain is sudden, is intense, very intense pain. It's a horrible pain. And the pain comes accompanied by hypotension, tachycardia, and the abdomen will develop signs of peritonitis. I mean, the clients immediately develop a board-like rigidity and rebound tenderness. That means that when the nurse is exploring the tenderness of the abdomen, while pressing is painful, but when releases, the pressure is worse, and it's called rebound tenderness. Of course, the client is going to develop a ileus paralyticus generally when this happens, and there is indication of placing a nasogastric tube to suction the gastric content, as happens in all the ileus paralyticus, and immediately prepare the client for surgery, IVs, etc., etc. Of the drugs used for the treatment of ulcers, don't forget that the antacids interact a lot with other prescription medications, because if prescription medications, oral medication, combine with antacid at the same time, those other prescription medications are going to be inactivated. For that reason, a common question in Nclex, how do you give, for example, an antibiotic in a client that is taking antacid? First, the antibiotic. Wait 1 hour and then the antacid. So give the important medication that you don't want to be which absorption you don't want to be impaired by the antacid 1 hour before the antacid. Remember that some antacids contain magnesium, and magnesium is contraindicated in renal failure clients. And the abuse of antacid can produce metabolic alkalosis. The other medications are not frequently tested. The H2 receptor antagonist, famotidine, cimetidine, okay, have little adverse effects and are given mainly at night to block the nocturnal secretion of acid. Cimetidine is a very old H2 receptor antagonist that could do the same as the grapefruit juice. Can inhibit the metabolization of toxic drugs that we can be taking, like amiodarone or statins, and make those drugs more toxic. It is the most important of the pharmacology of cimetidine to have in mind. And of the protoporphyrin inhibitors, it's important that the chronic use of protoporphyrin inhibitors inhibit the absorption of calcium and is a risk factor, especially for women, for osteoporosis. The protoporphyrin inhibitors should be given with antisthenic. They are not well absorbed if combined with food. So the ideal is to give the protoporphyrin inhibitors, omeprazole, esomeprazole, pantoprazole, all those prazoles, to be given half an hour before breakfast, frequently tested. There are two not frequently used medications for ulcer, like the misoprostol, is a prostaglandin, is an abortive medication. This medication should not be given to pregnant women. And the sucralfate is like a plaster that covers the ulcer, allowing the healing of the ulcer. Should be taken with empty stomach. to be able to cover the ulcer, and should not be combined. It's like the antacids, should not be combined with other important medication because inactivate the absorption of the other important medication. Of the viral hepatitis, guys, the most common questions is how it is transmitted, how the hepatitis is transmitted. You know that we have 5 types of main type of hepatitis. Hepatitis A is not common in America because it has a vaccine. Hepatitis A and B have vaccines, both, no? And people are vaccinated, so it's rare to have that. But hepatitis A sometimes appears in outbreaks because there is a person that is a carrier of the virus and is shedding the virus in the feces. If this person is, for example, a worker in a restaurant or is manipulating food, can contaminate a lot of people. The way of acquiring hepatitis A is fecal oral. The virus is eliminated through the feces. The portal of exit in the reservoir is the human, and the portal of exit are the feces. And the portal of entry is oral. So any contamination of food, water, etc., could produce this hepatitis in people that are not vaccinated. So frequently, when people travel offshore, where the hygiene is less strict as in the United States, they can, if they are not vaccinated, they can acquire this hepatitis. There is a food that is especially prone to transmit hepatitis. That is the raw shellfish. The raw shellfish, okay, is an important source of this type of hepatitis. Child daycare workers, you know, children are incontinence, are diapered. And as I said before, travelers are the people that are at the risk. All this, is important to know. The way of avoiding catching this is being vaccinated. And a part of that, the infection control is a standard precaution. Only if the client with hepatitis A is incontinent, so has loss of feces without continence, is when there is need of initiating contact precaution, CDC recommendation. But the best prevention is the vaccination. There is a type of hepatitis that is very similar to hepatitis A, that is the hepatitis E. The hepatitis E is also fecal oral, is not seen here in America. Is more common in underdeveloped countries, but is the same mechanism of transmission. It doesn't have vaccine. Hepatitis B and hepatitis C are blood-borne pathogens. It means that the blood and any fluid that comes from the blood, the majority of the fluids come from the blood. I mean, the breast milk comes from the blood. The genital fluids come from the blood. The urine comes from the blood. So all those body fluids, including the sexually exchange, are sources of those viruses. Hepatitis B has vaccine, but hepatitis C has not. Sexual activity is the way of acquiring both, probably the most common. Of course, blood transfusion in America, very rare. But before 1992, we didn't know that hepatitis C existed. And for that reason, before those times, the transfusion were not screened for hepatitis C. People that received blood transfusion before 1992, are at risk. The IV drug use is a risk factor for both hepatitis B and C. And because our blood-borne pathogens can be passed through the placenta from mother to child. People that work in hemodialysis and clients in hemodialysis are at risk of either one. Thank God, as I said before, the vaccine of hepatitis B makes it less probable, but hepatitis C is still a risk for healthcare workers because, you know, a needle stick or lack of standard precautions in the manipulation of body fluids can be a source of acquiring hepatitis C. The hepatitis B and hepatitis C has antiviral treatment for those clients that have the backlog of acquiring the disease. The infection control for either one is a standard precaution, doesn't require isolation. The same as hepatitis A in continent clients, okay? There is a form of hepatitis, or a virus hepatitis called hepatitis D. This is a co-infection with hepatitis B. It means that the client must have already hepatitis B, the virus of hepatitis B, to be able to become sick with the virus of hepatitis D. The mechanism of transmission is the same as the hepatitis B. The hepatitis B and the hepatitis C, if it is not diagnosed and treated, can produce cirrhosis and liver cancer. For that reason, it's very important to be diagnosed, okay, to be treated. A client that have hepatitis will have first a flu-like syndrome that can, you know, prolong for several days, and then we'll see that the urine becomes dark. It's a dark tea or black tea or coke color in the urine because there's excretion of bile through the urine. But then the feces become clear or white because there is no release of bile in the intestine. And of course, the client will develop jaundice. For hepatitis A, the treatment is symptomatic. Okay, the client doesn't have a special diet. Of course, avoid alcohol, avoid medications that are hepatotoxic. The diet is a healthy diet, but generally the client doesn't tolerate the greasy food, the fried and smelly and, you know, with a lot of condiments, okay, food, because, you know, the nausea. And but the diet is a healthy diet, liberal diet, and the rest is relative. There is no need of bed rest. You know. Meanwhile, the client feels tired, okay, can rest, and when the person feels better, can restart activities. It's very important the hand washing after going to the bathroom in client with hepatitis A. For hepatitis B and C, a part of this general treatment, there are antiviral treatment, okay, because otherwise they can become chronic. For cirrhosis, it's important that you know that they have 3 problems, among others. That is the portal hypertension that produces the ascites, and produces the ascites, the accumulation of liquid in the abdomen, and produces the esophageal varicose veins. The esophageal varicose veins have blood under pressure, and they can break and bleed massively. The other problem is that they have coagulation defects. Why? Because many coagulation factors are produced in the liver, and for that reason, they have prolongation of the PT and INR as if they were taking warfarin, and they need to be placed in bleeding precautions. And the last is that the ammonia is a substance that derivates from the metabolism, the catabolism of the proteins, and can, you know, impregnate the brain, producing coma. This coma is announced at the beginning with a movement in the hands called atherexis. That is explored, asking the client to dorsal flex the hands, and you'll see that they start making like a flapping, like a tremor, yes? That is the atherexis, and this is a consequence of the impregnation of the brain with the ammonia. Clients with cirrhosis should have a diet low in sodium because they have tendency to retain fluids, and for that reason they are in diuretics. The preferred diuretic is the spironolactone, but they can't receive other type of diuretic like the loop diuretics. In relation with the meals, it's important they need, while they are stable, we are in a chronic state of cirrhosis, they need a normal supply of proteins and so enough carbohydrates for the caloric requirements, But the low sodium is a constant. Remember that there is a medication called lactulose that is indicated to decrease the ammonia and to treat this altered mental status that produces the impregnation of the brain by the ammonia. And okay, there are other medications that could be used, like propranolol to lower the portal hypertension, and the spironolactone or other diuretic for the management of the ascites and edema. Medications that produce hepatotoxic or medications that produce sedation or depression of the nervous system should be avoided in those patients because, can make them worse. In the lab, you are going to notice that clients with cirrhosis have elevation of AST, ALT, the liver functions test. The prothrombin and INR is going to be prolonged. The ammonia is high, the albumin is low, the glucose tends to be low, and frequently they have pancytopenia. It means they have low red blood cells, low platelets, and low platelets. This stuff that you see here is called a spider, looks like a spider, no? Spider angioma. It's a cutaneous manifestation of part of the jaundice and the bruises and petechiae that are characteristic of clients with cirrhosis. And this is something dramatic, the esophageal varicose veins. There are many questions in English about the potential or prevention of the rupture of those varicose veins. Understand that if a person with these veins in the esophagus start doing Valsalva, for example, if they are constipating, bearing down, or lifting weights, or if they have nausea and have those dry heave that are, increasing the pressure of the body, they can break and the patient start bleeding. So avoid, all the maneuvers that increase the pressure inside the chest and the pressure in those veins. Have in mind that they use a ballooning tamponade of the esophagus with this sausage-shaped balloon that is inflated with air in the esophagus to make pressure in the bleeding varicose vein. Meanwhile, the doctor decide what to do with sclerosis, with endoscopic sclerosis or surgery in the client. When the clients place this ballooning in the esophagus, remember that in front of the esophagus, the trachea. So dislodgement of this balloon or pressure exerted by this balloon could produce sometimes respiratory distress. For that reason, always the nurse need to have at hand scissors for in the case that the patient is choking because the presence of the inflated balloon, to cut the tube that is emerging through the nose to quickly deflate the balloon and allow the patient to breathe. Gallstone, that is more common in women, fat women, multipara, and produce a lot of pain. And the solution is the surgery, the laparoscopic surgery. And the gallstones can be cause of pancreatitis, which can be mild, but also can be severe and hemorrhagic. When the pancreatitis is hemorrhagic, produce those signs in the abdomen, the colon signs and the Turner sign. Pancreatitis produces a horrible pain that makes the patient not tolerate the recumbent position. The patient is always leaning forward because it's the in fetal position, because the antalgic position. A lot of vomits, the intestine paralysis. and can be something serious because can conduct to hypovolemic shock. The tests that elevate in pancreatitis are the amylase and the lipase. The CT scan confirms the inflammation and even bleeding of the pancreas. The client needs to be placed NPO. Frequently, doctors orders nasogastric suction, medication for pain, IV fluids, and those are the important. The inflammatory bowel disease, is represented by ulcerative colitis and Crohn's disease. They are the two presentations of IBD. Both are inflammation and both are autoimmune. The ulcerative colitis is limited to the colon and rectum, but the Crohn's disease is from mouth to anus. Even if the distal ileum is the most affected part, all the GI tract is affected by the Crohn's disease. So in some ways, it's more severe. Crohn's disease also can have extraintestinal manifestation. Ulcerative colitis manifests by diarrhea and Crohn's disease by diarrhea. Both have abdominal pain. So abdominal pain and diarrhea, frequent bowel movement, is the common presentation for both. But the diarrhea in ulcerative colitis has mucus and blood. Never or not usual in Crohn's disease have blood. In the ulcerative colitis, there is a complication that is when the client is taking antidiarrheal medication that are contraindicated or opioids, they can develop something called toxic megacolon that requires a total colectomy. When the total colectomy is done, then the disease is cured, because if you don't have colon, then you cannot have ulcerative colitis. In Crohn's disease, this surgery is not indicated, but in Crohn's disease, sometimes they need to do surgery because they tend to develop fistulas, and to correct the fistula, sometimes they need treatment. The medication used for the treatment of this is anti-inflammatory medication like the sulfasalazine, and immune suppressors like adalimumab, infliximab, monoclonal antibodies, etanercept, corticosteroids, etc. Remember that there is a difference between ileostomy and colostomy. Ileostomy, what is open to the skin, is the ileum, because the colon doesn't exist anymore, like this client that had to be removed, the colon. In ileostomy, the effluent, what is coming out, is liquid, because remember, the colon is what absorbs the liquid of the intestinal content, the water of the intestinal content, making the feces solid. And of course, there is more loss of liquid, more loss of electrolytes, more loss of bicarbonate, and higher risk of disbalances, fluid and electrolyte disbalances. Please, always that you have more than 1,200 milliliters per day of output in ileostomy, report that to the doctor, because medications can be used to lower the outflow of liquid. It's important that because the ileum is narrow, that those clients need to be very careful with seeds, nuts, corn, pills, especially enteric-coated pills that are not dissolved in the upper part of the intestine, because can produce intestinal obstruction of the ileostomy. The skin around the ileostomy requires a lot of care to prevent the skin breakdown, because this liquid have active enzymes, digestive enzymes, that can produce severe dermatitis and the skin breakdown. In contrast, the colostomy, the effluent tends to be more solid, especially the most common colostomy that is seen in the left part, because the most common site of colon cancer is the rectum and the sigmoids. It's important that the aspect of either ileostomy or colostomy should be a beefy red or reddish pink, and it's normal to have some bleeding when you touch while cleaning the area, because it means that the stump is well irrigated. Any paleness, any purple color or dark color of the stump need to be reported immediately because it's a manifestation of gangrene or ischemia of the stump. You need to review in fundamentals how to change the appliance, okay? That need to be changed two times per week or 1 time per week. And remember that you only delegate to the CNA emptying the bag, emptying the poo-poo of the bag. That, by the way, need to be emptied when the bag is no more than half full. You never allow poo-poo to accumulate more than half the capacity of the bag, because then the weight of the poo-poo is going to disattach the appliance. Diverticulosis and diverticulitis are manifestations of the same disease. Diverticulosis is the most common conditions in older people and is consequence of chronic constipation. The diverticulosis is asymptomatic, no symptoms, and is found during colonoscopies for screening of cancer or barium enema. But one day, one of those pouches can become obstructed and then develop inflammation. Now will appear pain in the left lower quadrant, is the area where the diverticuli, okay, are present in the left lower quadrant of the abdomen. Appears pain, fever, and symptoms of inflammation, leukocytosis, etc. When the client is chronic, is having diverticulosis without inflammation, should have a diet rich in fiber. But when the client is having the diverticulitis that frequently is hospitalized, is either NPO or with a no fiber diet until the treatment with antibiotics resolve the diverticulitis. The majority of the time, the diverticulitis is treated with antibiotics. After several days with antibiotics and a clear liquid diet and no fiber diet, the diverticulitis cured, and of course, the client is left with his or her chronic diverticulosis. Okay, so now with that, I was exploring some questions in ATI. So let's see how ATI treats this topic of GI. Let's see this question. A nurse is administering a tap water enema to a client who is constipated. During the administration of the enema, the client states he is having abdominal cramps, pain. Which of the following actions should the nurse take to relieve the client discomfort? Okay, you need to understand, I don't have here. Just a moment, let me see. Just a moment, guys. I'm trying to explore what they have because it is a new. What happens if I use this? Okay. No idea. Okay, here it is. Okay, when you're administering an enema, okay, the bag with the liquid, okay, here is the client in Sin's position, yeah, and here is the liquid coming. The height in relation with the anus, the height of the bag will determine the speed with which the liquid is entering here in the intestine, and if the liquid is entering too fast, distends the intestine too much, and then appears pain. So you should have, okay, you should have an elevation no more than 12 to 18 inches, 1.5 feet. So foot, 12 to 18 inches. But if you are administering the liquid, okay, to the client, and the client start complaining, okay, complaining of pain, what you do? You can have different options in the question. You can transitory, you don't discontinue the enema. The enema is going to continue, but you can clamp, okay? You can clamp the enema until the pain disappears. Or very simple, you lower, you reduce the height. You reduce the height of the bag, and then the liquid will start passing slower, and as a consequence, the pain will disappear. Makes sense, no? Makes sense. So the answer is lower the height of the solution container. Guys, if you don't understand anything that what I'm saying, please tell me, okay? Tell me. Ok, yo no sé cómo inactivar esto. Okay. How I move this? Just a moment, guys, because I'm lost. Okay. No, it's here. Stop sharing. No. Annotate. Okay. Okay. The other option were encourage the client to bear down. No. Allow the client to expel some fluid before continuing. No. Stop the enema and document that the client did not tolerate the procedure is not necessary. Okay. So let's continue seeing how ATI treats this topic. Okay. A nurse is caring for a client. No, let me. A nurse is caring for a client who has 9 days post-operative following a total laryngectomy. Okay, this is a surgery of the airway. It's a surgery of the larynx, probably with cancer. The nurse removes the client's nasogastric tube and initiates oral feedings. Which of the following statements should the nurse make? Tuck your chin when you swallow so you won't choke. It is no longer possible for you to choke on or aspirate food. Yes. You should have no trouble swallowing fluids. I will add a thickener to your liquid to prevent aspiration. Notice that notice that when you are reading here, tuck your chin when you are swallow, so flex your neck, is correct for people with dysphagia. This is really with dysphagia. I will add thickener, dysphagia. But this statement says something different. You don't have dysphagia. Why the client with laryngectomy doesn't have dysphagia? Guys, remember that this is the mouth. This is the mouth, okay? The mouth, okay? The mouth. Okay, this is the mouth, okay? Here's your tongue, the mouth, okay? By the way, here comes also the nose. And this is the throat. The throat has a hole here and a hole here. The hole here goes to the trachea, yeah? To the trachea, and from the trachea to the lungs. Basic anatomy. And the hole here is the esophagus that goes to the stomach. Goes to the stomach, yeah? When a foot, I have to change the color. Okay, when the food comes here, or the liquid, okay, the liquid, and if you have dysphagia, the liquid of the food can go to the trachea. Yeah, it is true. But when you have a laryngectomy, what they do, they eliminate the larynx. So now the larynx is going to be a cul-de-sac. The larynx is going to be here, close, no more larynx, the trachea is here. And now you have here a hole called tracheostomy, through which a tracheostomy tube need to be the rest of your life. It happened to the people that had larynx cancer. So when this client is eating, there is no way, so now the food is coffee, okay? No way for the food to go to the trachea. So there is no need of any of these precautions. So it is a nice question, something that maybe you never thought about, to know that when there is a... Ok, entonces ahora como es que yo hacía. Okay. When there is a... No, how you turn off? Just a moment, guys, because the thing is... Stop sharing, no. Yo puedo dejar esto fijo. Okay, yo puedo dejar esto fijo. Okay, close. So I assume that everybody understood because nobody is making questions. Let's see the next questions. A nurse is providing instruction of 52 years old client who is scheduled for a colonoscopy. The client reported that he has not had the procedure before and is very anxious about feeling pain during the procedure. He is afraid of pain. It's like me. He's a coward for pain. And which of the following will respond to the nurse is appropriate? You won't feel pain because you are going to be sleeping is the answer. You are going to be totally sleeping. Don't worry. This is disqualified. Never say that. This is called false reassurance and ignores the client's concerns. Never, when you see that, it is disqualified. No simple, doesn't work. Don't worry. Most clients dislike the prep more than the procedure itself. It's a stupidity. The patient is not concerned about the preparation. The patient already went through the preparation. He's concerned about the pain. Okay, before the examination, your provider will give you a sedative that will make you sleepy. More than sleepy, you're going to be sleepy. Okay, so you never notice anything when you have the colonoscopy. Let's see this. I know you are anxious, but this procedure is recommended for people your age. It's true, but this is not a solution that the patient is afraid of the pain. And after you have signed the consent form, we can talk more about this. No, before signing the consent, the clients need to have clarified any doubt. Okay, so no problem. We move. Yes. A nurse is reviewing the lab data of a client with acute pancreatitis. The nurse should expect to find an elevation with the following value. Calcium is low in pancreatitis through a process called saponification. The calcium is low in pancreatitis. Red blood cell count. Red blood cell count doesn't need to change unless there is a massive hemorrhage. Magnesium is not affecting pancreatitis. Amylase, they are asking about elevated, no? Elevation, see, yes, there is elevation, okay? There is elevation of the amylase. We say the amylase and lipase are the enzymes that allow you to diagnose pancreatitis, no problems. Okay, pancreatitis, another question. A nurse is admitting a client with suspected appendicitis, identified where the nurse will palpate to assess for pain at McBurney point. Hotspot image. Okay, so you are going to click here in the right lower quadrant, okay, in the right lower quadrant. ¿Cómo me salgo de aquí? Okay. Sorry, me salí. It is a new function of Teams. Okay, they are trying to emulate Zoom. And first time because it updated. This is a recent update, and I am not familiar with so need to be. I need to learn how to use this. Action preview. See, this is from Teams, not from ATI. Okay. Yeah. Sorry. Okay. Ya hice esta. Okay. Nurses teaching self-management to a client who has hepatitis B. Self-management. Which of the following instructions should the nurse include in the teaching? You may donate blood. No, 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 no. This is a contraindication to donate blood. Not even body organs is true. For the remainder of their life, it is correct. Consume high protein diet. It is questionable. Okay, rest frequently throughout the day. And take, okay, this is incorrect. You cannot take, okay, medication that is hepatotoxic. So don't take acetaminophen every 4 hours because it's a very strong dose. Rest, yes, it's okay when in the acute hepatitis, in the acute symptoms, the client rests when they feel tired. And normal diet, normal protein diet, no? Normal protein diet. Okay? And adequate nutrition should be maintained, but protein intake should be moderate when the liver's ability to metabolize protein byproducts is impaired. The nurse should recommend a diet high in carbohydrate and moderate in proteins and fat. Okay, then the modern tendency is not to limit proteins in the clients with liver disease. In the past, in my times, we limited the intake of protein, but the modern tendency is not to limit protein, okay? And the patient is going to rest when they feel tired, okay? Ya vieron how ATI treat this point. A nurse is teaching a client who has prescription of a nasogastric tube to treat pyloric obstruction. Everybody knows what is the pyloric valve. Sometimes there is pyloric obstruction in an adult because there is an ulcer, for example, near this area, and appears what is called pyloric syndrome. It's similar to this pyloric hypertrophic, congenital pyloric hypertrophy for newborns. So the client starts vomiting, and a nasogastric tube is placed until the obstructions improve. Generally, this kind of acquired obstruction for edema because of an ulcer, disappears without surgery. Which of the following rationale for the use of a nasogastric tube should be the nurse include in the teaching? Okay, determine the pH of the gastric secretion. There is no reason for that. Supply nutrients, no, cannot be fed. Decompress the stomach. It is the correct. It's going to be connected to a low pressure intermittent suction, yeah, and it's going to remove the gas and the liquid that accumulates in the stomach until the obstruction subsides. Administer medication, no. Okay, so no doubt on this. A nurse is instructing a client how to decrease the nausea. Okay. A nurse is instructing a client how to decrease the nausea associated with chemotherapy and radiation. Which of the following statement indicates understanding of the teaching? I will eat smaller meals if I feel nauseated. I will eat foods that are served at room temperature. You know that when there is nausea and anorexia, the food at room temperature are better tolerated than hot food. So it is correct. It is a correct statement. I will drink more liquid with my meals. No, because it's going to distend the stomach and produce more nausea. And should drinks the liquids between the meals, the same as as in GERD and dumping syndrome. I will increase the amount of unsaturated fat. No, fats are digested very slowly and produce nausea. And obviously, if the client has nausea, best is to rest. Okay, not to eat until the nausea disappears with the medication. Okay, it is not very good question, but yes, it's the best answer. A nurse is preparing dietary instruction for a client who has episode of biliary colic. It is gallstones. It is a gallstones that produces a biliary colic, pain in the right upper quadrant radiated to the right shoulder. For chronic cholecystitis, which of the following instructions should the nurse include in the teaching plan? This is about diet, no? Include food high in starch and proteins. No reason for have high in starch and proteins. Include food high in fiber. No reason for that. Avoid fat. Yes, the client that suffers of gallstones should avoid fat in their diet. Avoid food high in sodium. No reason for that. Okay, we agree. A nurse is caring for a client who has diverticular disease. When palpating the client's abdomen, in which of the following locations should the nurse expect the client to report abdominal pain? Left lower quadrant. Remember, left lower quadrant. The others are not. Why? Because the most of the diverticulitis are in the sigmoid, and the sigmoid is in the left lower quadrant. Sigmoid and descending column are the sides of the diverticulosis. A nurse is teaching a client who has hepatitis A, Which of the following information should the nurse include? If family history increases your risk of acquiring hepatitis, this is not hereditary, so it's not true. Hepatitis A infect the kidneys. No. Manifestation of the virus are similar to flu-like syndrome. It is true. The incubation of the virus 5 days. No, the incubation of the virus for hepatitis A is 30 days up to 45 days. And for hepatitis B can be even 3 months. 3 to 6 months. It's a very long incubation period. And during the incubation period, the client is infective. 5 days is too little. A nurse is teaching a client how to do fecal or cold blood testing. Which of the following statement by the client indicates a need for further teaching? What is wrong? I will continue my low dose of aspirin therapy regime. Further teaching, what is wrong? I will continue my low dose aspirin therapy regime. And said, not aspirin interfere with the testing. This statement does not require clarification. Okay, ADI says that the aspirin doesn't produce gastritis or bleeding. It's only the NSAID. It's an ATI opinion. Okay, so be aware of that if you have this question.
Perfect. I
Yes.
think I've done this question before, and I was very confused between that. Of course, the
Okay,
coumadin.
okay. Remember that you need to survive. You need to survive your ATI. If you have an ATI, okay,
According to them, is
yeah, you know, but aspirin is also withheld. Okay, is also withheld. Okay, aspirin and NSAID and corticosteroids, because everything depends on the clients, and the doctor need to authorize a discontinuation of a. For example, you can have aspirin over the counter, and you can recommend avoid over the counter aspirin, but a client that, for example, had a stroke or a transient ischemic attack and is taking aspirin, or has a myocardial infarction, or has a catheterism with a stent, and doctor prescribed aspirin, and now the nurse need to do a fecal occult, you need to consult the doctor, because it's risky to tell the client to discontinue the aspirin, because now the client is having, you know, a stroke or not anything that is not good, and we cannot assume the responsibility. It depends a lot. So it's a question that is contentious. No, you need to discuss that with your instructor. I will refrain from eating raw food and vegetables. There is no problem, okay, having this for the fecal occult, except the one that I mentioned: radishes, broccoli, and ¿cómo se llama? Turnip are vegetables that should be avoided because produce false positive. And I will avoid steak and other meat. It is correct. And I will continue taking my Coumadin as prescribed. So it is incorrect. The client should discontinue anticoagulants for 1 week prior to the testing. This is require clarification. Remember, guys, consult with your provider. For example, my person. I am a person that suffers atrial fibrillation, paroxysmal atrial fibrillation. I don't know in which moment, morning, afternoon, or night, I'm going to have a paroxysmal of atrial fibrillation. I need to check my anticoagulants every day. And I don't dare to stop my anticoagulant, because I could have an atrial fibrillation and I could have a brain thromboembolism, and my brain can be seriously damaged. Do you understand that I won't accept any nurse telling me to discontinue my anticoagulant for 1 week for that? So it's okay. It's interesting, the question, but this question is very contentious. Okay, don't dare to tell a client discontinue your anticoagulant. If a person is taking Coumadin, which is a potent anticoagulant, is because it has a serious indication to take this. And the nurse is not going to discontinue for 1 week this anticoagulant, and is not going to recommend the client to discontinue that. Please don't do that. Sometimes people that write questions don't think twice the damage that can be producing in a nurse student when they make those statements. Okay, so guys, always consult with your physician. Okay, the discontinuation of those medications, they are like Coumadin, a prescription medication. This is not over the counter. It is a prescription medication. And any doctor that is assuming the risk of giving an anticoagulant to a client because it's needed is not going to discontinue for any of these tests these medications unless is contraindicated. So take care with this question. Don't take very seriously this question. Okay. A client who is scheduled for a barium swallow asks the nurse why a laxative is necessary following the procedure. Yes, the barium tends to solidify, to dry, and can produce fecal impaction. That's why, okay, the laxative helps eliminate the barium. It is correct. It is correct. Because barium, when you swallow the barium, you are going to be eliminated barium for several days. And as I said, it has a tendency to dry up and to produce fecal impaction. So it is correct. Generally, doctors prescribe stool softeners and Docusate, and it's enough. Swallow. The nurse is providing teaching for a client who has new diagnosis of gastroesophageal. The nurse is providing teaching for a client who has a new diagnosis of gastroesophageal reflux disease, the GERD. The client asks about foods he should avoid eating. Fried food, alcohol, meat, milk, greasy food, stuff with caffeine. Which of the following foods should the nurse tell him to avoid? Non-fat milk. Okay, there is the non-fat milk. Okay, they are asking the nurse to avoid. Okay, milk stimulates the production of acid, should not be taken neither. Okay, they say that either no fat milk can be taken. Chocolate should be avoided because it has caffeine, so it's okay. Apples, no problems. Oatmeal, no problems. Okay, so chocolate is the answer to this question. Very good. Chocolate, caffeine, and tea should not be used in patients with GERD. The nurse is providing the child instruction to a client who has rheumatoid arthritis and a prescription of oral betamethasone. Betamethasone is a glucocorticoid. Glucocorticoids are hard for the stomach and produce ulcer. Which of the following statements should the nurse make about to take this medication? Have that in the morning with food. Take the medication between meals, not with meals. Take the medication with orange juice, not with meals. Take the medication with milk. Okay, could be with milk. And take the medication with anti-stomach, not with meals. So glucocorticoid should be taken with food. It is glucocorticoid, most of the dose should be taken in the morning to mimic the circadian rhythm that the glucocorticoid have, but should be taken with food. Can be milk, can be whatever. Glucocorticoids are not impaired. The absorption is not impaired by the food, so can be taken, liberally with food. A client is prescribed lansoprazole. It's one of the parasols. Okay, 50 milligrams PO once daily. Which of the following times should the nurse administer the medication? Remember, empty stomach, preferably in the morning. So 30 minutes before breakfast is correct. Is correct. The absorption of this medication is affected by the food, so that's why it should be taken with empty stomach. A nurse admits a client to the medical department who reports nausea and vomiting that worsen when he lies down. Antacids do not help. The provider suspects acute pancreatitis. Which of the following lab test results should the nurse expect to see? Amylase, lipase, okay, increased serum amylase, increased white blood cells, increased lipase, and decreased calcium. Remember, the calcium drops in pancreatitis. So the answer is correct, no doubt with this question. A nurse is caring for a client who has liver cirrhosis with ascites, bleeding, esophageal varicose veins, and portal hypertension. And not recognizing which of the following lab findings are indicating that the client gastrointestinal tract is digesting and absorbing blood. Okay, we have the BUN, blood urea nitrogen, A1C. A1C has nothing to do with protein. Chloride has nothing to do with protein. Bilirubin has nothing to do with the protein. Guys, blood is mainly protein. The hemoglobin is a protein. Yeah. And when a client is bleeding, the blood that is in the GI system, the blood that is in GI system is absorbed. Those proteins, okay, degrade first in ammonia. ammonia. The proteins that are absorbed to the circulation are transformed in ammonia, and the liver, the healthy liver, transforms the ammonia in urea. That is measured with the blood urea nitrogen. No? And the urea is excreted by the kidneys. No? The kidneys. If they say if there is an increase in the intake of protein, I mean the blood that is bleeding, you anticipate there is an increase in the ammonia and increase in the urea, that if you have good kidneys are going to be eliminated by the kidney. So it's okay. It is something that can be accepted as correct. Elevate blood urea nitrogen. The other, you can rule out the other options. I continue fighting with this program. Okay, let's see. Sometimes obey, sometimes doesn't obey. Okay. A nurse is talking with a client. Okay. A nurse is talking with a client who has cholelithiasis. Cholelithiasis is gallstones. It's the other name to gallstone. Cholelithiasis. And is about to undergo an oral cholangiogram. Oh, this is a very old, bro, really old test in which the client with gallstones, it is a test that was done before the use of the ultrasound for the diagnosis of gallstones. And then the client with empty stomach had to swallow several tablets of a radiological contrast that contained iodine. And then this iodine was absorbed, go to the liver excrete that in the bowel, and then after several hours, they do an X-ray. It was called oral cholangiogram. They don't do that anymore. The ultrasounds, okay, are much better than this. Much cheaper than this. But okay, but there is a question about this. Which of the following client statements indicate the nurse to understand of the procedure? They are going to examine my gallbladder and duct. Yes, it is correct. Soon those shock waves will get rid of my gallstones. No, it's this lithotripsy. The shock waves to eliminate gallstones is lithotripsy. In the past, they used lithotripsy, that is still used for nephrolithiasis, for kidney stones. But in the past, they used lithotripsy for gallstones. Now it doesn't make sense. It complicated more the situation. So now they do the cholecystectomy. They don't do that. Okay. I have a camera put down my throat. It's an endoscopy. They'll put medication into my gallbladder to dissolve the stone. No, they don't do that anymore. Okay. Okay, perfect. This is okay. No contention there. A nurse is caring for a client who has a peptic ulcer disease. The nurse will monitor the client for which of the following findings or indications of gastrointestinal perforation: pain, shock, hyperactive bowel sound, no, ileus paralyticus, the intestine paralysis, paralytic ileus. Horrible pain, I agree. And it's sudden. Okay, it's a horrible pain and it's horrible. With symptoms and signs of peritonitis, rigid abdomen, ¿cómo se llama? Rebound tenderness, and it's true. The clients evolve to shock. It's a catastrophe. It's a catastrophe. You need to go to surgery. Increased blood pressure, no. By the contrary, can drop. And bradycardia, no. Tachycardia. Okay, this is a good question. A nurse is caring for a client following an esophagogastroduodenoscopy upper GI endoscopy procedure. Which of the following assessment is the nurse priority? After the procedure, okay, let's see, pain, nausea, gag reflex, level of consciousness. Level of consciousness is a mild sedation. It's a conscious sedation is recovered. Nausea is not important. Pain is not usually pain. There is pain because a complication happens. Okay, the priority is the gag reflex. Yes, and until the gag reflex doesn't return, the client needs to be MPO. You know that. You know that. A nurse is preparing to administer PO medication to a client who has myasthenia gravis. Which of the following actions should the nurse take prior administering the client medication? Of course, you need to check if the client can swallow. How the client empty his bladder? No. Put up the side rails in the client bed? No. Ask the client to take a few sips of water. Okay, this is a good question. Why do you ask the client to take a sip of water? Because this is the way that a nurse explores if the client has dysphagia or not. If the client has dysphagia and a little amount of water go to the trachea, nothing is going to happen because the water is not going to produce a bad aspiration. The problem is when the aspiration is food or the aspiration is a medication. So that's the way of a nurse explores, okay, for dysphagia. So it is a good question. So what you do, especially with myasthenia gravis, that you know they have problem of dysphagia. Before giving a tablet, okay, check if the client can swallow. And it is a good option. Place the clients in low Fowler position, no high Fowler, to facilitate the medication. A nurse is preparing a client who is scheduled to undergo a paracentesis, which is the following position should the nurse assist the client for this procedure as high as tolerated, high Fowlers. Why? Because the patient is breathing with difficulty. And of course, this position also collects the liquid in the lower part of the abdomen. No side lining, no leaning forward, no supine. Very good. A nurse is caring for a client who is postoperative following abdominal surgery. Which of the following findings should indicate a nurse that the client's peristalsis is returning? Well, the best is, yes, passage of flatus. The evidence says that the best evidence that the client is returning the peristalsis and can start eating is the passage of flatus. It's much better than the return of the bowel sounds, and is much better. Abdominal distension is not requested for a cup of no, and hypoactive bowel sounds in 2 quadrants, no. Flatus is the best evidence of return of the bowel sounds of the peristalsis. A nurse is planning care for a client who has viral hepatitis. Which of the following actions should the nurse include in the plan of care? Wash your hand. Provide a high carbohydrate diet. Administer acetaminophen? No. Encourage eating 3 large meals? No, because they have nausea. When you have nausea, no big meals. Include high protein snacks is not indispensable. Nevertheless, when you go, for example, to Kaplan insists in increasing protein in clients with liver disease. So you are going to discover that nursing is not a exact science like mathematics or whatever. You are going to have different opinions. Okay. In reality, it's a normal diet. That is, if you go to make a review, a peer review, a serious site, you are going to notice for hepatitis a normal diet. Avoid alcohol, avoid drugs that can be hepatotoxic, and the client eats what the client wants. Avoid big meals, because when you have nausea, if you fill your stomach, then you have nausea and you are going to vomit. Avoid the liquid with the meals, because for the same reason, to avoid the distension of the stomach. Drink the liquid between the meals. And the content of the diet is a normal diet. It's a healthy diet. There is no limitation. In the past, come dulce, but it is not supported by evidence. Okay. A nurse is caring for a client who has returned from PACU after traditional cholecystectomy. Traditional cholecystectomy has a big wound, a big oblique wound in the right upper quadrant. In which of the following positions should the nurse place the client? Semi-fowler. Yeah, semi-fowler. Yeah, after surgery, semi-fowler. No. Seems no. Dorsal recumbent is flat. A dorsal recumbent is supine but flat. Okay, semi-fowler. Nothing special in this one. I skip this. Yeah. A nurse is providing teaching about ileostomy care to a client, which is the following statement by the client indicates in need of further teaching. I will empty my pouch when it becomes 1/3 fluid. Okay, what do you opinion that? 1/3 to a half fluid. And it is more further teaching, so it is correct. I will be certain to take enteric-coated medication. No, you should not be taking enteric-coated medication. Remember that we said that the enteric-coated tablets can produce obstruction. I will change my entire pouch system at least weekly. Okay. I will use caution when eating high fiber foods. Yes, because they don't have constipation. They have, by the contrary, diarrhea. So high fiber food is not convenient when you have an ileostomy. A client is about to undergo an abdominal paracentesis in which of the following positions are the same. High fowler. Upright. Another, yes, upright. And there's a provider's office instructing a client who is scheduled for an outpatient barium swallow. Which of the following statement by the client indicates an understanding of the teaching? I can have clear liquids up to 4 hours before the test. They say that NPO 8 hours because it's important to have empty stomach. I should expect light colored stool after the procedure. Yes, white poo-poo. You need to warn the client. It is correct. I will require an IV catheter? No, because it's swallowing, it's not IV. I need to bring a snack because I will hear all day. No need of being all day. A nurse is assessing a client who has peptic ulcer disease. Which of the following findings should the nurse identify as the priority? The priority of peptic ulcer disease: perforation, bleeding. Okay, epigastric discomfort, dyspepsia, constipation, hematemesis. Of course, hematemesis is the priority. Bleeding. Okay, esto. The nurse is caring for a client who has ulcerative colitis and is teaching the client about the common link with chronic disease. Both are autoimmune, both are inflammatory bowel disease. Which of the following information should the nurse include? Both are inflammatory. Both begin in the rectum? No. Both manifest fistula? No. Crohn is the one that has fistula. Both require frequent surgery? No. A nurse is reviewing the provided prescription for a client experiencing a paralytic ileus following an appendectomy. Which of the following actions should the nurse expect to take? So, ileus paralyticus, okay, what to do? Amenity antacid? No. NPO, nasogastric suction. Provide bulk forming agent? No. NPO, and a bulk forming agent is a laxative. It's from something called Celiac with P. Celiac, and it's not NPO. Insert nasogastric tube. If there is ileus paralyticus, a nasogastric tube usually is inserted. Apply a thrush. Thrush is a device that is used for people with hernia that don't want to have surgery, and it's like a suspensorio en español. It's like like a underwear or something like this to hold the hernia. It is nothing to do with ileus paralyticus. A nurse is providing care for a client who had a laparoscopic cholecystectomy. This is the one that is 3 little holes in the abdomen. Which of the following is an appropriate nursing action? Place the clients in a supine position post-operative, semi-Fowler. Yes, ambulation is important after laparoscopy to promote the reabsorption of the carbon dioxide that is insufflated in the abdomen. Offer the client ice cream? No, this is for tonsillectomy. Instead, the client is too fatty, too much fat. The client not to lift over 4.5 pounds. It is the limit. 5 pounds. Yes, 5 pounds is the limit of the weight that we can lift if we are recent surgery. A nurse is providing discharge teaching to a client has GERD. With the following statement by the client indicate understanding of the teaching. The type of food I eat does not affect this condition. Yes, it's affected by this. I will sleep on my left side. No. For GERD, it's better to sleep in the right side. Even if it's a contentious topic, there are some people that think the opposite. Okay, I will eat a snack just before going to bed. No, I will sleep with the head of my bed elevated. Yes, this is the best answer. The rationale for which in GERD being turning to the right is better is because the gastric emptying will occur sooner. And once the stomach is empty, there is not reflux. Because the stomach empties to the right, from left to right is the direction of the peristalsis of the stomach. And that's why this position will facilitate, okay, see. Okay, a nurse is teaching a client who is pre-op for a colectomy, so it's going to have part of the colon removed. The client asks the nurse why he needs a large bore nasogastric tube. Which of the following statements should the nurse make? Okay, to decompress. The tube is a routine standard following this type of surgery. This is not an answer. The tube will allow us to provide you with nutrients. No, it's going to be NPO. The tube will remove gas and fluid from your stomach. Yes, decompression. This is the reason for the nasogastric tube connected to gastric suction. The tube can be explained to you once you are stable after surgery. If this is not a correct answer. A nurse is assessing a client in 3 days post-op following abdominal surgery and note the absence of bowel sounds, abdominal distension, and the client passing no flatus, so it has an ileus. Which of the following condition is the nurse expect? Ileus paralyticus, paralytic ileus, correct. Cholecystitis, radiculitis, wound lesion, no. A nurse is caring for a client who has cirrhosis and has a prescription of bumetanide. Bumetanide is a loop diuretic. When delivering the client's lunch tray, which of the following items should the nurse identify as contraindicated for the client? We have baked potato, which is carbohydrate. Stewed tomatoes, which is mainly carbohydrate, have potassium. Ham sandwich, hams has a lot of salt. And this client should have a low salt diet. So I agree with the question. In milkshake, okay, there is no contraindicated to milkshake. Okay, because the salt diet, the most important to restrict in cirrhosis, the salt. A nurse is teaching a client who has history of ulcerative colitis and a new diagnosis of anemia, of course, because this is bleeding. There is the diarrhea with mucus and blood. Which of the following manifestation of colitis should the nurse identify as a contributing factor for the development of the anemia? Chronic blood loss. Remember that ulcerative colitis, there is ulcers in the colon and loss of mucus and blood with the diarrhea. A nurse is caring for a client who has a postoperative ileus and the nasogastric tube have drained 2,500 milliliters in the past 6 hours, a lot of liquid. Which of the following electrolyte imbalances should the nurse monitor for this client? This liquid is rich in chloride, in hydrogen, and in potassium. So the main consequence of this loss of liquid is an metabolic alkalosis with hypochloremia and hypokalemia. So what do we do? Elevated sodium, no. Decreased potassium, yes. Elevated magnesium, no. Decreased calcium, no. Low chloride, low hydrogen, and then alkalosis, and low potassium. Because it's what is the composition of the gastric juice, a part of water, no? Okay, a nurse is teaching a client who has a hiatal hernia about dietary recommendation. When you see hiatal hernia, it's the same as GERD because it's a common cause of GERD. So whatever you learn in the management of GERD, apply that to hiatal hernia. Which of the following statement indicates an understanding of the teachings that are applied? I will consume less caffeine and fewer spicy food. Well, it is correct. I will sleep with the head of my bed elevated. This is correct. I will try not to gain weight. It is correct. Gaining weight when you have a big belly pushes your stomach. It's like the pregnancy, and then you have reflux. I will lie down for 1.5 hours after meal. No. I will drink less fluid. No. You will drink abundant fluid, but between the meals. It is here, I will drink less fluid. No, this is not true. You don't need to restrict fluids. Okay. I will drink less fluid is incorrect. Although the client should avoid fluids containing caffeine and alcohol, there is no indication for client to have a hiatal hernia to decrease overall fluid intake. With the meal, yes, but not in general. Take care with those traps that the question have. No? A nurse is assessing a client who has cirrhosis. Which of the following is an expected finding for this client? Moist skin, spider angioma. Do you remember the spider angioma? Yes. Tarry stool? No, because if the client is not bleeding, that doesn't need to have tarry stools. And blood in the urine? No. They can have tarry stools. If the varicose vein starts bleeding, they can have tarry stools. But this is not mandatory to all the clients with cirrhosis. I think I did, no. A nurse is interviewing a client who has acute pancreatitis. Which of the following factors should the nurse anticipate finding in the client history? Gallstones. The most common cause of pancreatitis is the gallstones. A part of binging alcohol, high triglycerides, some medication, for example, the glucagon-like peptides, the incretins that now liraglutide, semaglutide, exenatide, these new medication for type 2 diabetes that are used by people to lose weight, yeah, can produce pancreatitis. Some medications, some antiretroviral medication for HIV can produce pancreatitis. Okay, so you need to have an idea that some medications can, rarely, but can produce a side effect pancreatitis. A nurse is planning care for a client who has cirrhosis of the liver. Which of the following actions should the nurse include in the plan? Cirrhosis. Administer diuretic for furosemide, yes. Implement the low sodium diet, yes. Administer warfarin, no. Measure the client's abdominal girth, yes. Encourage weight lifting, no, because the varicose vein. Okay. Valsalva should be avoided. Right, a lot of question about GI here. And there's providing teaching for a client who has experienced an acute episode of gastritis. Which of the following instructions should the nurse include in the teaching? Limit drinking milk. Take NSAID for pain. Avoid drinking alcohol. It is correct, no? The nurse should teach the client to avoid drinking alcohol, yes. Limit extraneous exercise. There is no need for that. Okay, yes. Avoid alcohol for gastritis. Okay, guys, next class we continue with the rest of the question. Any question? Are we okay?
Yeah, Professor.
Thank you,
Okay.
Professor.
Thank you, Professor.
Okay, so see you next time.
Thank you very much.